Hi everyone, today's video is on the topic evaluation of pediatric stridor. Why do you think pediatric stridor necessitates a separate discussion? This is because in children the airway is much smaller in diameter, and whenever the diameter falls down, the resistance will increase multifold. To be precise, the resistance will increase 4 times with a fall in diameter of the airway. Why is it so? Because the Poiseuille's law states that the flow rate is directly proportional to the fourth power of radius. So that's why it is very important that we discuss about the evaluation of pediatric stridor. Now coming to the question, what do you mean by stridor? Stridor is the high-pitched noise that is produced by turbulent airflow through obstructed airway. The extrathoracic airway has got a tendency to collapse during inspiration and to expand during expiration. So whenever there is an obstruction in the extrathoracic airway, it gets exacerbated during inspiration and gets better during expiration. That is why inspiratory stridor is seen in extrathoracic obstruction, whereas in case of intrathoracic obstruction, what happens is that due to the negative intrapleural pressure, the intrathoracic airway expands during inspiration and collapses during expiration. So it is an expiratory stridor that is produced by an obstruction in the intrathoracic airway, whereas a biphasic stridor is seen when there is an obstruction at the level of subglottis and cervical trachea. Why is it so? Because subglottis is a complete ring, isn't it, formed by the cricoid cartilage, and in case of the cervical trachea, it is also having cartilaginous support in its entire length, and it does not collapse during inspiration or expiration. So if there is any obstruction at this level, it will be a biphasic stridor, that is, the stridor will be present in both inspiration as well as expiration. Why? Because there is no expansion of airway during inspiration or expiration. Before going to the evaluation of pediatric stridor part, let us go to the various causes of pediatric stridor. The most important thing that you have to be aware of are the various congenital causes of pediatric stridor. What is the most common congenital cause of pediatric stridor? In fact, the term congenital laryngeal stridor has been used to denote one particular entity. What is that? Yes, congenital laryngeal stridor, or CLS, means laryngomalacia. Laryngomalacia, the term itself denotes the softening of larynx. Malacia means softening. Okay, and because of the softening of larynx, what is happening? The epiglottis is folded and there will be very short ariepiglottic fold. There will be a lot of redundant mucosa. The epiglottis will be flabby and it will be in omega shaped fashion. Even though in neonates it's always omega shaped, it will be more pronounced, and because of that, while taking inspiration, there will be a stridor. Okay, so the first important thing you have to remember is laryngomalacia. The second most common cause of congenital stridor is bilateral vocal cord palsy. Okay, you will always have to look for a bilateral vocal cord palsy, especially if the child is having stridor from birth itself, because laryngomalacia will not present at birth. It will take about 2-3 days for the presentation of laryngomalacia stridor. Only when you have a bilateral vocal cord palsy or a subglottic stenosis or laryngeal web or any such structural lesion, it will result in stridor in the day 1 of birth itself. Okay, so you have to be very careful about that. The third most common cause of congenital stridor is laryngeal web. As you can see here, this is the anterior glottic web. Anterior glottic web is associated with 22q11.2 deletion syndrome, that is Dijorg syndrome. So whenever you see a case of anterior glottic web, you also have to evaluate for that. Okay, and yes, this is the fourth common cause, that is subglottic stenosis. Subglottic stenosis can be congenital and it may be associated with anterior glottic web, or it can occur as an acquired cause, because whenever you take history, you have to ask for history of any prolonged ventilation. If there has been any history of intubation of the child, especially preterm child, there might be history of intubation that can result in subglottic stenosis. Okay, now another thing that you have to look for is some birthmark, as you can see in the head of Mikhail Gorbachev here. Okay, why? Because there could be some subglottic hemangioma. Okay, subglottic hemangioma can also result in stridor. Okay, and yes, another important cause of laryngeal stridor that you have to think of is laryngeal cleft. Laryngeal cleft child will also have history of aspiration. When you are giving him milk through the mouth, there will be aspiration. Okay, because of the laryngeal cleft causing the communication. Okay, now what is other cause? It could be due to a tracheoesophageal fistula, or there might be Peary-Robin syndrome. When you see a child with a small jaw and when there is retrognathia, you have to think about Peary-Robin syndrome. Now this is how a micrognathia is resulting in airway obstruction. Okay, and another important cause is bilateral choanal atresia, that also can result in stridor. And whenever there is bilateral choanal atresia, it improves on crying. Usually most stridor causes will decrease on cry. Bilateral choanal atresia is usually associated with Charge syndrome. Charge syndrome includes coloboma of eyes, heart defects, atresia choanae, retardation of growth, genitourinary anomalies and ear anomalies. Okay, so these are the various congenital causes of stridor that you have to be aware of, and there are certain acquired causes, and sometimes for undergraduate exam you will be asked what are the febrile causes of stridor. Okay, yes, the first important thing that you have to think about is acute epiglottitis, and you might be aware of the thumb sign, right? In X-ray lateral view, when you take, you can see the swollen epiglottis like this, and that is what is meant by the thumb sign. And how will the child present to you? Apart from stridor, there will be dysphagia, and because of the severe dysphagia, what happens is that there will be drooling of saliva. Okay, because of the odinophagia associated with acute epiglottitis. Because of the pain, the patient won't be able to elevate the larynx, and because of that, the patient will have drooling of saliva. Then there will be difficulty in breathing along with voice change. So these are, and because of the respiratory difficulty, what happens is that the child adopts a particular tripod posture, as you can see here. Okay, to improve his breathlessness, he will have to adopt this particular tripod posture. Okay, now what is the other cause? The laryngotracheobronchitis is, or croup, is another cause, and in this case what is happening is that the child will be having a severe seal-like coughing, barking cough will be present in the child. And yes, when you take an X-ray AP view, what you will be able to see is the steeple sign. Because of the laryngotracheobronchitis, there will be steeple sign. Okay, so these are the various features of acute laryngotracheobronchitis or croup. Okay, now what is another important cause that should never be missed in a child is a foreign body. Foreign body bronchus can occur. It can be a foreign body that causes immediate obstruction, as you see here when the child has taken in a coin, or it could be a forgotten foreign body such as a peanut, which the child might have aspirated long back, and because of that the child might be having recurrent episodes of pneumonia. Okay, so these are the various causes of stridor that you have to think about. And how will you evaluate for a child with stridor? First of all, you have to ask from when the child is having the stridor. You should be taking a detailed perinatal history. Okay, whether the child was born premature, preterm delivery had occurred, whether he was intubated, all these things have to be asked in detail, because intubation can result in subglottic stenosis, right? And what else you have to ask for? Whether the stridor is present since birth, because if it is present since birth, it is unlikely to be laryngomalacia, but still the possibility can't be ruled out unless and until you do the nasopharyngeal laryngoscopic examination. And another thing that you have to ask is relationship with cry, whether the stridor is getting worse with cry. Most causes of stridor becomes worse with cry, and that includes laryngomalacia, bilateral vocal cord palsy, subglottic stenosis. Everything will get worse with cry, because while crying the child will be putting in more effort, right, and because of that it will get worse. Okay, but in case of bilateral choanal atresia, what happens is that the patient's stridor will improve by crying. So if there is a history of improvement in stridor with cry, that is indicative of bilateral choanal atresia. Okay, now what else you have to look for? If there is any improvement with sleep, then that is indicative of a laryngotracheal cause of obstruction. But whenever the sleep is making it worse, that is indicative of a pharyngeal obstruction, and there will be stertor more than stridor associated with it. Okay, and so whenever you are having a child with chronic adenoiditis, the child will be having stertor, and along with that it will get worse during sleep. Okay, you should also be asking for history of apparent life-threatening events, that is there will be dyspnea, cyanosis. Such spells also you have to be asking for, because that is indicative of the severity of stridor. Okay, and yes, if there is such history, that is an indication for surgery in case of laryngomalacia. Okay, now what else you should be asking for? You should be asking for feeding history. If the child is able to take breastfeeding properly, if the child is unable to even breastfeed properly because of the effort taken for that, then that will be indicative of a severe stridor. Okay, so even in a case of laryngomalacia, which can resolve in more than 95% of cases with conservative management, these are all indications for surgery, that is having recurrent episodes of cyanotic spells, then failure to thrive due to inability to take feed, okay, and severe chest indrawing. All these are indications for surgery in laryngomalacia, and of course in type 3 laryngomalacia also you will have to go for surgery. And another thing that you have to ask for is whether the stridor is improving or getting worse in supine position. Okay, most cases of stridor will be worse in supine position, whereas it becomes better in prone position, especially when you are having any pedungulated mass in the larynx. Okay, and in case of Pierre-Robin syndrome, when there is any retrognathia and glossotosis, also when you are in prone position the stridor will improve. Okay, so these are the various things that you have to ask for, and of course you have to ask for the cry of the child. Okay, whether the cry is hoarse or not. If there is history of hoarse cry, that is indicative of a vocal cord palsy or a vocal cord papilloma, especially when it is a young mother, firstborn child, prolonged vaginal delivery. All these can suggest a case of vocal cord papilloma, and when the cry is very weak, it is indicative of a glottic web. Okay. Another important history that you have to ask for is history of any aspiration, that is history of any cough during food intake. All these are indicative of certain pathologies like laryngeal cleft, tracheoesophageal fistula, and vocal cord palsy. So if you are taking a detailed history itself, you will get an idea of what it can be, and these are the things that you have to look for in history while evaluating a child with stridor. Now coming to the examination part, how will you examine the patient? First of all, you have to sequentially examine the oral cavity, oropharynx, ear, nose, all these have to be examined. Okay, and of course you have to look for chest retractions. It will be in the form of suprasternal retraction, then there will be intercostal retraction, subcostal retraction, epigastric retraction. Along with that there will be flaring of alinaceae. All these are indicative of the increased work of accessory muscles of respiration. Okay, and whenever there is accessory muscles of respiration working, that means the obstruction is very severe, and that is why the child have to act like that. Okay, and then you have to examine for the cold spatula test. Look for if there is any decreased fogging in one area. For example, in choanal atresia there will be no fogging at all. because of the atresia part. Okay, that is the next thing you have to do while examining the child. And of course you have to auscultate the child. Okay, the stridor has to be auscultated in the and for that you have to keep the stealth over the nose, over the open mouth, and over the neck, and even in the chest, so as to localize the area of stridor. Okay, there should be a conscious assessment of the jaw and tongue size as well. That is, you should be looking for retrognathia and glossoptosis, because that also can result in stridor, right? And along with that, you should also be observing the child while she or he is feeding, because if there is any history of aspiration, then it is significant to know if the feeding is normal. Okay, if the patient is able to feed properly, if there is any cough on feeding, all these has to be assessed. Okay, what is the next step in evaluation? You have to do a flexible fiber optic laryngoscopic examination. It might be difficult in an older child, but otherwise you can easily do a flexible fiber optic laryngoscopic examination. It is done through nasal cavity usually, but in less than 1 month old child, sometimes it will be difficult to pass even pediatric scope through the nasal cavity, and since the child is edentulous, you can even attempt passing it through the oral cavity as well for fiber optic laryngoscopic examination. And yes, in this video you can see how the laryngomalacia presents. Okay, this is a case of laryngomalacia. Now, X-ray soft tissue neck lateral view and chest X-ray AP view has its own value. As you have already seen, the thumb sign in acute epiglottitis and the steeple sign in laryngotracheobronchitis can be obtained with plain chest X-ray itself. And CT neck is indicated when you are having a patient suspected of having subglottic stenosis. Okay, you have to know the exact extent of the subglottic stenosis. For that you will need to take a CT neck. Okay, and even if it is a case of a laryngeal web, you will have to take a CT neck to rule out subglottic stenosis. And if there is any history of aspiration in the child, you have to do FEES and fluoroscopic assessment. Okay, FEES and fluoroscopic assessment will help you know whether there is any laryngeal cleft or tracheoesophageal fistula causing the problem. Okay, so these are the various investigations to be done in a patient who is having stridor. But the gold standard investigation is of course laryngotracheobronchoscopy. For that you use Hopkins Rhodes telescope for assessment of the larynx, and the patient will need a Mayo stand for suspension laryngoscopy, and then you examine. And while examining, as you can see in this video, you will have to palpate to rule out laryngeal cleft, and of course you have to look for the cricoarytenoid joint mobility, and if there is any intra-arytenoid joint fixation. All these has to be done under anesthesia. If you are suspecting tracheomalacia, you should be using a small bronchoscope, and it should be withdrawn from the area suspected of having the malacia, and you should not be using any positive pressure during that, because the splinting of the area by the bronchoscope and the positive airway pressure can mask the malacia segment. Okay, so that is very important. And of course dynamic assessment of the larynx is also important. This has to be done as the child recovers from anesthesia with the help of a 30-degree Hopkins Rhodes telescope. And so this is how you systematically approach a patient with stridor. You have to think about the various causes, and with that cause in mind you have to take a good history, and with the history you have to go for a focused examination, and then you have to investigate the child, and through these investigations you will be able to get into a diagnosis, and with the help of that diagnosis you will be able to treat the child. Okay, that's all for today's video. Until next video, goodbye.